Okay, it's going live on YouTube, and then we'll start the fifth e-dialogue. Welcome to all of you, and thank you for joining. And there are several attendees joining online. And before we start the Let's Fix Our Food New Life webinar or e-dialogue series, I would like to welcome our director, Dr. Bharti Kulkarni, and thank you for accepting our invitation to be here, and Professor Bruce Neal, Dr. Jha, and all our speakers and panelists. And as you all know, we've been conducting these e-dialogues with an intention to come up with policy briefs that would actually form the basis for policy advocacy for bettering food environments, especially for adolescents. Uh, and New Life initiative, as you all see, is part of the Let's Fix Our Food initiative, which we started in 2022. But since 2025, RTSL, the Resolve to Save Lives, has been supporting this initiative called the Nutrition Literacy and Improvement of Food Environments, in short, called New Life. Let's Fix Our Food New Life. And combining the eight e-dialogue series that we've done under LFOF till 2025, and this is the fifth one, and this is the 13th one in all that we're doing. And of these, we have brought out approximately 9 to 10 policy briefs, five of which were the first version were released in March 2025 by DG Dr. Rajiv Bahl and also the member Niti Ayog, Dr. VK Paul. And we now have updated those five, and we've added five more to our entire chunk of policy briefs, and they will be released very soon, hopefully next month. So we're planning for a big release of all these. So that's the brief background about the Fix Our Food e-dialogue series. And today we're very happy to host this e-dialogue on low sodium salt substitutes in India, evidence, health impact, and policy implications. As a rule or as a tradition in every e-dialogue, since it deals largely with adolescents, we've been having adolescent youth ambassadors represent as speakers or panelists. But since this is a very technical topic, we've got a adolescent youth ambassador to join us, but she would be, introducing our guests in the panel today. And Salt has a lot of historical association with all of us, especially in Indian tradition and culture, from the iconic pinch of the salt that Mahatma Gandhi held in his hand, that part Dandi March, to today's need for just a pinch less than what we are eating. India's relationship with salt has come a full circle, and once a symbol of freedom, salt is now a reminder that we should reduce excess salt, and that could help limit or liberate many millions from the growing burden of hypertension. And yesterday was the World Hypertension Day, and this entire month we are going to conduct the hypertension month and then create awareness. Thank you all for joining once again. Before I request my colleague Kriti to introduce our director, I just have a few administrative announcements to make. This e-dialogue is expected to be more interactive, but the attendees can post all their questions or doubts or maybe points that they want to raise in the chat box or in the Q&A box. And the panelists can ask questions at the end of each presentation, but before that, I request you to please raise your virtual hand. These are the few announcements, and then as the structure demands, we have speakers, one giving us an overview of the international perspective and the research, one speaker giving us the national perspective, and then we have a panel of speakers giving us an overview on different aspects of making low sodium salt available and usable in India. That is not a short introduction, though, but I had to give all these. And then I'll now request Ms. Kriti to introduce our director, and then who doesn't need an introduction in general, but it's the format of the e-dialogue. And then we quickly have this introduction. Kriti, over to you.
Good afternoon. It's an absolute honor to introduce the director of our institute, ICMR National Institute of Nutrition, Dr. Bharti Kulkarni. Dr. Kulkarni is a visionary physician scientist who brings over 20 plus years of profound expertise to transforming public health and pediatric care in India. Backed by a distinguished global academic background, she holds a DCH from the University of Pune, and MPH from Johns Hopkins University, and a PhD from Queensland University of Technology, Australia. Throughout her career, she has led massive multi-centric national studies that directly shape national policies on maternal and child nutrition, anemia, and dietary diversity. She is a prolific author with over 130 peer-reviewed global publications, the recipient of numerous prestigious research grants, and an elected fellow of the National Academy of Medical Sciences, India. We are incredibly privileged to learn from her leadership every day, and her insights provide the perfect foundation to open this event. We warmly welcome you to deliver the address, ma'am.
Thank you so much, Kriti, for the generous introduction. I'm very, very pleased to welcome all the speakers, panelists, and all the attendees of this fifth dialogue on a very important topic of low sodium salt substitutes in India. Like as Dr. Subbarao said, that we recently celebrated the World Hypertension Day, and this year's theme is controlling hypertension together. Check blood pressure regularly and defeat the silent killer. So when we talk of defeating the silent killer, high sodium intake in India continues to be one of the most important modifiable risk factors, and Indians are known to have higher sodium intake, more than double than what WHO recommends. WHO recommends 2000 milligram per day of sodium, whereas the average intake among Indians is 4400 milligrams per day. And this is clearly a very, very important risk factors, and we need to address this. And we know that cardiovascular disease, including hypertension, is one of the most important risk factors driving the disease burden in India. And under the and on the platform of Let's Fix Our Food Initiate Consortium, where NIN is very proud to lead, we have had multiple e-dialogues on important topics related to food environment, how these shape our risks related to non-communicable diseases. And as you will hear more about the Let's Fix Our Food Consortium, but briefly, I would like to mention that it is a multi-partner consortium for knowledge exchange, where which brings together researchers, clinicians, public health experts, as well as policy makers and program implementers. And the aim is to translate scientific evidence into concrete policies and program pathways. So, without taking further time, I'm sure that we have an excellent panel of speakers and panelists, and you are all very, very eager to listen to them. So once again, I would welcome Professor Bruce Neal, Professor Vivekananda Jha, Dr. Sharon from our sister ICMR Institute, Dr. Syed Imran Farooq, and all the panelists for this very important e-dialogue. Thank you once again.
Thank you, ma'am. Now, I think I've already done my opening remarks, and I'll just skip that part. It's my privilege to invite Dr. Imran Said from Resolve to Save Lives to give an overview of New Life Initiative. But before that, my colleague Tavleen will introduce him.
Thank you, sir. Hello, everyone. It is my pleasure to introduce Dr. Imran Said Farooq, Executive Director at Resolve to Save Lives India. He is a seasoned public health leader with over 2 decades of experience in strengthening health systems and advancing population health. Dr. Farooq brings deep expertise in stakeholder engagement, public private partnerships, and sustainable health system development, and has led multidisciplinary teams across Southeast Asia for the past 8 years. He has played a key role in driving national efforts in health financing, capacity building, and private sector engagement aligned with national health priorities in Indonesia. Dr. Farooq currently serves as Chief of Party for USAID's flagship TB private sector project in Indonesia. We are delighted to have him join us today to share his insights and experience. Welcome, sir.
Thank you. Thanks for that generous introduction. Just I would like to say that I'm currently leading Resolve to Save Lives as the Executive Director for Resolve to Save Lives and based in Delhi. So thank you. Thanks, Dr. Bharti and NIN for this opportunity to provide an overview of Let's Fix Our Food initiative or the New Life initiative. As we all know, and it has been made quite clear by our Honorable Prime Minister, that country is witnessing a rapid rise in obesity. And that is also along with diabetes and hypertension. And it's not just among adults, but also adolescents are suffering from it. It is driven in part by increasing consumption of foods that are high in fat, salt, and sugar. Poor diets are now among the leading risk factors for cardiovascular disease and other non-communicable diseases in the country. And when we talk about poor diets, we are talking about diets which are ultra-processed foods. We are talking about the diets which are empty calories without nutrients. We are talking about the food which are high in HFSS. And this Let's Fix Our Food initiative, which was launched in response to this public health challenge, supporting the shared vision of creating a healthier food environment in India. I would like to acknowledge that under the NIN's leadership, this initiative has produced impactful policy briefs, as Dr. Subbarao mentioned, that it is almost 9 or 10 now in last 2 years, and has hosted national dialogues and engaged in high-level stakeholders on critical issues such as salt reduction, healthier oils, nutrition, literacy, and school food environments. We are also thankful to the continued support of other member organizations in the consortium like UNICEF, IEG, WHO, GHAI, WFP, IFPRI, and many more. This is another full circle that we began last year with the first webinar on salt reduction, and now we come here for the low sodium salt substitutes discussion today. We have seen that these efforts has laid strong foundation for cross-sector collaboration and amplified adolescent voices in shaping the National Nutrition Agenda. In this phase 2 of New Life or LFOF New Life, the focus was on research and capacity building. There were broader coalition engagement. We had sustained engagement with Niti Aayog, Ministry of Health and Family Welfare, Ministry of Education, and FSSAI to advance the front of package labeling, HFSS taxation, and marketing restrictions. This unified platform has been an initiative which has strengthened and coordinated multi-stakeholder public health action in the last couple of years. And the key to success has been NIN's leadership, collaboration with partner organizations, future-leaning approach, focus on latest national as well as international approaches, and an aligned goal of healthier food environments for all Indians. So as we get into our final dialogue of this series, I would like to say that salt reduction, which has been endorsed by WHO as one of the most cost-effective public health strategies, with demonstrated potential to lower hypertension, stroke, and cardiovascular diseases. LSS could be the key intervention for salt and sodium reduction in the country. LFOF reflects the commitment of NIN as well as partner organizations to work collaboratively with an evidence-based approach to address diet-related non-communicable diseases in the country. We at RTSL are proud to continue our partnership with NIN and other consortium partners to build on this momentum and drive long-lasting improvements in the public health system of the country. Thank you, and I wish all the best.
Thank you, Dr. Imran. Thank you very much. Now we step into the most important, deliberation of today's e-dialogue. We have three speakers, very well known for their work and then their commitment to public health and then reduction of hypertension at a public health scale. As the format is, we will have an international speaker, and we'll have two speakers who will give us a national perspective on low sodium salts. It's my pleasure to invite Professor Bruce Neal. He's joining from Switzerland, if I'm not wrong, within the 2-hour window that he's got before he has to jump off to another meeting. But nevertheless, I thank him very much for his commitment to the cause. And I request my colleague Ishani to quickly introduce him so that we can, hear him present about the global scenario.
Good afternoon, everyone. We are honored to welcome Dr. Bruce Neal, Professor of Epidemiology at Imperial College London and Senior Professorial Fellow at the George Institute for Global Health. Dr. Neal is internationally recognized for his expertise in large-scale cardiovascular disease trials and pioneering research on sodium reduction strategies. He led the landmark salt substitute and stroke study, which demonstrated the significant health benefits of potassium-enriched salt substitutes in reducing stroke and cardiovascular risk. His research has consistently focused on developing evidence-based approaches to lower stroke incidence, cardiovascular events, and premature mortality through population-level sodium reduction interventions. Currently, his work is centered on translating potassium-enriched salt strategies into scalable public health solutions with global impact. Please join me in welcoming Dr. Bruce Neal.
Thanks very much for that kind introduction. I'll just get my slides up, and hopefully that's now sharing with you okay. I'd like to just begin by thanking you for giving me this opportunity to speak to you, and really wanting to congratulate NIN for their leadership on this, in particular Dr. Kulkarni, also Dr. Syed at Resolve to Save Lives, such a key partner in trying to make this work happen, and of course my colleagues at the George Institute, led by Dr. Jar, and everyone else on the call. It really is tremendous to see this work progressing in this way. So I'm going to just give you a quick overview of the international research behind this strategy. I do have two brief disclosures to make relating to the provision of potassium-enriched salt by corporations for some of the trials we've done, but I don't think they constitute a substantive bias in terms of what I'm going to talk to you about today. So I thought it would just be worth starting by reminding people how salt intake has changed over evolution. You can see in the pictogram on the right there that daily sodium intake during most of hominid evolution was very low, about half a gram a day. But as we heard from Dr. Kulkarni, average consumption globally now is far above that, at about 4 grams of sodium a day, or about 10 grams of salt. Less well recognized is the parallel change in consumption of daily potassium. Potassium is abundant in fresh fruits and vegetables, and potassium consumption was about 10 grams a day for our hominid ancestors, but now has dropped to only about a quarter of that, with the progressive change in diets worldwide, from diets based on fresh fruits and vegetables to diets based on processed and packaged foods. And this means we have a very different level of consumption and a very different ratio of consumption of not just sodium, but also potassium. So I don't need to tell any of you about the adverse effects of excess sodium on blood pressure, but worth also noting that insufficient potassium intake is another really important and less well recognized cause of high blood pressure, and it adds to the effects of excess sodium consumption. Blood pressure, as you would again be aware, is the leading cause of the most common things that kill people around the world: strokes, heart attacks, kidney disease, and very likely also dementia, which is increasingly being shown to be highly blood pressure dependent. Importantly, we have strong evidence of the reversibility of blood pressure and indeed some of these cardiovascular risks with both sodium reduction and potassium supplementation, and the two combined, which is really going to be the focus of this session today and what I talk about. So why is potassium-enriched salt such an important thing to be talking about? And the key reason is that while everyone has recognized for a long time the harms caused by excess sodium and has tried very hard to do something about it, it's proved very difficult. And that's despite the best efforts of the WHO, United Nations member states making commitments, and very large numbers of people around the world trying to make it happen. It isn't for a lack of will. It's just difficult because if you cut salt from food, it tastes less salty. And that is something that it's very difficult for people as individuals to accept, and it also doesn't fit the commercial model operated by the food industry. So it's a pretty basic, pretty simple problem, but it's proved a very difficult one to overcome. I won't go into the details in terms of potassium, but there has been a recognition that we should eat more potassium. The main way that's driven is by trying to get people to eat more fresh fruits and vegetables. And that too is facing a real uphill battle because as nations industrialize and as the food system industrializes, it pushes us to diets that are based on lower potassium, processed and packaged products. So salt substitute is a very simple technological way to try and address this. All a salt substitute is a regular salt, which is made of 100% sodium chloride, in which part of the sodium chloride has been replaced with potassium chloride. The greatest evidence base is around a 25% potassium chloride, 75% sodium chloride mix, which was developed because it was widely acceptable. Most people at that combination of sodium and potassium don't taste a substantive difference between regular salt and potassium-enriched salt. And of course, the behavior change becomes much easier because if you're switching regular salt for potassium-enriched salt and it tastes the same, you don't end up with a less salty product. And that is clearly more acceptable to individuals and should also be more acceptable to industry as well. So there is pretty strong evidence in this space. This was the large trial that really changed the landscape. It was called the Salt Substitute and Stroke Study, done by colleagues in China. It randomized 21,000 people in 600 villages to either continue with their regular salt or switch to this salt substitute combination, and then they were followed for 5 years. And what it showed was that It lowered blood pressure, not a lot, but by about 3.3 millimeters of mercury. And we have to remember here that blood pressure is an incredibly powerful determinant of both stroke and coronary risk. Probably the least talked about result from the trial was that at 5 years, 92% of the people assigned to use the salt substitute were still using it. Now, we were providing it for free, certainly, but I've done many drug trials over the years, and if we had 92% adherence at 5 years, we would be astounded. We'd be lucky in most studies to get 50% adherence at 5 years. So this really is a highly tolerable, highly acceptable intervention, and far more tolerable and acceptable than trying to cut salt intake. So this was the primary result. Among the 21,000 people who were high-risk individuals, there were about 3,000 strokes recorded. There was a 14% reduction in the risk of stroke and a very significant p-value. And there were also very clear reductions in the risks of cardiovascular events. So that's strokes, heart attacks combined. And also it reduced the risk of premature death. So a really compelling finding. Now, there is a legitimate question about the safety of potassium-enriched salts. If you eat potassium-enriched salts, you eat more potassium. And there is a subset of the population that can accrue a risk as a consequence of that. And that is primarily people who have serious kidney disease. It's almost certainly not most people who have kidney disease. It's almost certainly only affects those who have significant problems handling potassium, who have got the worst kidney disease and who represent just a few percent of the population. I'll leave Dr. Jha, who's much more experienced, to probably add some commentary on this. But it's worth noting that in the SAS trial, we didn't test people's kidney function. We just said, if you know you have serious kidney disease, do not join the trial. And in the SAS trial, we saw no excess of risk of hyperkalemia. And indeed, in no trial completed to date has there been any evidence of clinical harm from hyperkalemia. That said, in one Chinese trial, which included some people with kidney disease, there was evidence of an increase in blood potassium levels, but no increase in harm from those elevated blood potassium levels. So it's something we need to think about, but it's much overcalled. And the net benefits from switching to potassium-enriched salt will far outweigh the potential harms caused in the subset that have serious kidney disease and don't know about it. There are also one or two medicines, if you take a potassium-sparing diuretic or if you take a potassium supplement for another reason, then you may not wish to use a potassium-enriched salt as well. But most people who are taking those medicines would, of course, know about it and avoid potassium-enriched salts. So another key consideration in terms of rolling out potassium-enriched salts is where does the salt in the diet come from? This map shows you in the black-colored countries that the majority of salt for the majority of the world's population still comes from salt added while preparing, seasoning, or preserving foods in the home. So a major target for us in India and elsewhere around the world has to be the discretionary salt that people receive from the public distribution system or buy from stores in supermarkets, corner stores, and elsewhere. In more developed economies, the majority of the salt comes from processed and packaged foods, and we need a strategy that targets the food industry to address that. The reason why we're so interested in potassium-enriched salts is that a recent modeling study that we did suggests the potential for very large global health gains. If you could switch the entire world's salt supply from regular salt to potassium-enriched salt, you would prevent about 3 million premature deaths every year and another 10 million non-fatal strokes, heart attacks, serious kidney disease events. And that constitutes about 16% of all cardiovascular deaths and about 17% of all disability adjusted life years from cardiovascular disease. So it really is a very high potential intervention. There's also significant potential for improving hypertension control, which is a focus both for Resolve to Save Lives and also for the World Health Organization. The World Health Organization did last year launch a guideline specifically on the use of lower sodium salt substitutes or potassium enriched salts, and this is a huge step forward. So it's all now really about how do we achieve impact. We have a very broad-ranging program of work which spans from recognizing that if the world wants to change its salt supply, it's going to need to produce a lot more potassium chloride. It can do that by either expanding current production from refining of potash, or it may also be possible to recycle potassium chloride, which is produced as a waste stream from a number of industries. The recycling option is particularly attractive because that may allow us to bring the price of potassium chloride down to a similar price to sodium chloride. Currently, potassium chloride is about 4 times more expensive than sodium chloride, and in a 25-75 mix, that means that potassium-enriched salt ends up being about twice the price of regular salt. That's a manageable price difference because salt is a very low-cost commodity for many of the world's population, but it is a major disincentive to some of the least well-off, and it's also a major disincentive to industry take-up. We're spending a lot of time thinking about how do we get potassium-enriched salt into the retail and manufacturing sector. Mandatory sodium levels for food categories is an important strategy there because the food industry will turn to potassium-enriched salt if it has to hit sodium targets. I've talked about the importance of addressing addressing discretionary salt used in the home, and we're working hard on advocacy and awareness with groups that span government, healthcare, and direct-to-community. So I've really summed up probably what the next steps are. A big effort to raise awareness. There are still some knowledge gaps that we can fill in terms of the science. I mentioned the importance of having more evidence in people with CKD, evidence about preventing the rise of blood pressure in children, potentially as a treatment for preeclampsia in pregnancy. I think we need more country-specific projects because if you do work in a country, it's a great way to get interest, and we also need to solve for those supply and price constraints. I'm just going to finish now with one final reminder, which is that we have changed the world's salt supply once before from regular salt to iodized salt, and that is widely recognized as one of the big public health successes of the last century. We have an opportunity now to change it again and to deliver at least as big health gains from not just iodizing, but also potassium enriching. So I'll stop there, and if there are comments or questions, very happy to hear them. I'll also stop sharing.
Thank you, Professor Neil. That was very interesting, and then you just gave us a complete overview of the issues that are confronting us. One question that often is asked is that, if everyone demands potassium-enriched salt and then demand for it really increases, countries like ours where potassium is very difficult to source, how would they? Do we have enough sources around the world to help us get there? That's a question that a lot of people ask.
Yeah, so it's a good question. So the answer is yes, definitely. So potash, which is the primary source of potassium chloride, is everywhere. It's in almost all countries. It's mined at scale, however, in a relatively smaller number of countries at present. So particularly Canada, China, Belarus, and Russia. The challenge is that even fewer countries refine it from sort of agricultural grade potash, which is mostly used for fertilizers, into the food grade or pharmaceutical grade product required for the food supply. And increasing the capacity, I mean, it's not technically difficult. It's just that you've got to get the demand there to drive the industry to invest in that production capacity.
Thank you. One question from YouTube is that what does it take to convince the industry to use potassium
Yeah.
enriched salts? Yeah.
So industry is interesting because it's price. I think it's price, which is the key. Because I mean, salt is typically only 1 or 2% of most food products, and it's a low cost part of those food products. So even if you switched it to something that was twice as expensive, it would have almost no impact on the final cost of the product. But the person in the company who buys the salt and maybe normally pays, sorry, I'm going to have to do it in dollars, but $20,000 or $30,000 for the salt for the year, they're not going to pay $60,000 for the salt for the year unless there is a really strong reason for them to do that. And the only really strong reason for them to do that would be if the government mandated sodium targets, which force the industry to switch to potassium enriched salt. Most countries don't do that at the moment, but that would probably be the most powerful driver.
Thank you so much. Thank you for that. I think in the interest of time, we'll move to the next talk, and then we will love to have you with us if you can manage to till the end of the webinar series. Thank you very much. And now it's my pleasure to invite Professor Vivekanand Jha to please make his presentation on low sodium salt substitutes in India, and most importantly, cardiovascular benefits, opportunities, and informed use across populations. But before he starts his talk, it's my pleasure to invite my colleague Manasa to please introduce him.
Good afternoon, everyone. It's my pleasure to introduce our second speaker for today's session, Dr. Vivekanand Jha. Currently he serves as the executive director at the Global Institute for the George Institute for Global Health India, and also held a prestigious position as a chair of global kidney health at Imperial College London. As a clinical scientist and global expert in kidney disease, transplantation, and non-communicable diseases, he leads clinical trials, policy-relevant community research, and global collaborative research network. His research focuses on the burden and socio-economic impact of kidney disease in low and middle income countries. He also serves as an advisory to the Government of India and WHO on health policy and research, recognized for translating research into clinical practice and public health impact. With over 500 plus public peer-reviewed publications, he also has fellowships of leading national and international medical academies. With deep depth of his expertise in salt reduction strategies, we welcome you, sir, for your grateful insights.
Thank you very much, colleagues at National Institute of Nutrition and Resolve to Save Lives, and all the other distinguished panelists, the director of the National Institute of Nutrition and friends. I'll also start by sharing my screen. Just give me 1 second. Are you able to see my
Yes, sir. Yes.
slide
Yes.
in the part? So,
But sorry, sir, but the slide is I think the margins are going away out of the screen. I think you should put it in 100 and then
Okay.
expand it. It's in 156. So if you can bring it back to 100 and put it in slideshow, it will work good.
Is it okay?
Yeah.
All right. Thank you. Thank you for that tip. Very helpful. So you not only do salt substitute and nutrition, you do this as well. Following Professor Bruce Neal's presentation, giving you really the compelling evidence globally, and he is the single most important person currently who has generated compelling evidence around the benefits of low sodium potassium containing salt substitutes around the world. So let's see and now what is the situation currently in India. So again, there are a bunch of numbers here which I don't need to get into because I'm pretty sure everyone is fully aware of the large and growing burden of cardiovascular disease and hypertension in India, and also the fact that a large proportion of these individuals are not diagnosed in time and are not managed appropriately, leading to very high complication rate, which includes coronary artery disease, peripheral artery disease, stroke, chronic kidney disease, etc. The tragic part is that a large proportion of our population dies of these complications much, much earlier compared to those in the Western countries. Again, repeating some of these well-known facts, excessive salt intake is linked to about 1 in every 3 occurrences of hypertension. The number of deaths that is attributed to high salt intake is not trivial. This statistic is perhaps imprinted in everyone's mind is that in India we consume around 8 to 11 grams of salt. And as has been said before by Subbarao and others, that discretionary salt accounts for a large proportion of our salt consumption, although that is changing with the increasing availability of processed foods. So these are the common sources of salt in the Indian diet. We have salt added during cooking, which remains the largest source perhaps currently. But we are also very avid consumers of pickles and chutneys and poppers and namkeen of all types. As I said earlier, packaged foods are increasingly making inroads, and now it is not uncommon to see them even in remote rural areas. Type of shops which earlier used to sell books now sell packaged foods. Restaurant foods, people often really find more salty food to be tasty. And the last is also important is that people often get lulled into a false sense of security by shifting to some kind of alternative salt, alternative types of salt like pink salt, black salt, rock salt, without realizing that they contain similar sodium levels than the usual sodium chloride salt that they consume at home. So question is, how do salt substitutes lower blood pressure? And Professor Bruce Neal did give you a glimpse of the possible factors. But we know that reduced sodium level lowers fluid retention and vascular pressure. Equally important is the higher potassium intake, which helps relax blood vessels and improve sodium excretion. This is very important and much less appreciated by the broader healthcare community, including, unfortunately, the medical community. Professor Neal has showed you evidence from the SAS trial and some other trials as well, including from India, and I'll show you those, that meaningful reductions in blood pressure can be achieved by simply changing the normal salt to potassium-containing salt. And there is this modeling kind of studies which have told us that population-level sodium reduction could substantially reduce cardiovascular events and premature mortality. So these are data from a study which we conducted at patients and patients with chronic kidney disease, but also from general population at PGI Chandigarh. This is a very recent study where we showed that the actual salt intake was 7.5 grams almost. But very importantly, and the reason I wanted to show this slide is the potassium intake, which is 1.4 grams. Professor Bruce Neal gave you the figure of 2.5 grams in the Western countries, and we are even lower than that, despite the fact that we are supposed to be vegetarians and consumers of plant-based diets much more than those living in the Western countries. So this is something that perhaps should hit home much more for us here in India than it would in the Western countries. Now let's review the current guidelines and how those guidelines position potassium-enriched low-sodium salt substitutes from the Indian perspective. We are, again, by now very familiar with the WHO guidelines, recommend the use of lower sodium salt substitutes as a safe and effective way to reduce sodium intake and lower blood pressure. However, according to WHO, this is not applicable in certain populations, pregnant women, children, and individuals with kidney impairments or with compromised potassium excretion state. Despite the fact that this is somewhat paradoxical, given that some of these individuals may actually stand to benefit a lot by consuming this kind of salt. Not everybody, but most of this population that is currently listed as this guideline not being applicable. Similarly, the European guidelines, the Asian guidelines, the Australian guidelines, they all are on the same page, as is the National Hypertension Task Force on Low Sodium Salt Intake, which says that there is substantial evidence that reducing the sodium content and replacing it with potassium reduces the risk of cardiovascular disease and blood pressure. Based on a large extent by the evidence generated by Professor Bruce Neal, the China guidelines in 2024 recommended using and promoting low sodium salt, and they have embarked upon a strategy for implementing and promoting use of this particular salt substitute by taking a number of actions. With a focus on households, they are also focusing on older adults and also on food industry. We heard about the challenges associated with engaging food industry already. In India, we have a number of current programs and policies which are by and large recommending consumption of less than 5 grams of salt a day. But if we don't do something different, it's pretty safe to say that going to meeting this target is not going to work for a huge majority of population. The national guidelines, again, contributed in quite a substantial manner by the National Institute of Nutrition, also recommends potassium at 3.8 grams a day. According to the research that has been conducted, in addition to the research paper that I showed you from our group, again, the George Institute led the salt substitute in India study, which showed a significant impact in lowering systolic and diastolic blood pressure. The same impact was shown, in fact, to a greater extent in another study by Dr. Fatima et al. And the plural study, which looked at the consumer perspective, found that the participants linked salt to hypertension, but were largely unaware of the benefits of low sodium salt substitute for blood pressure and cardiovascular disease reduction. So if you look at these numbers, the blood pressure reduction is actually similar to what would be achieved by one single antihypertensive pill. So if we are somehow able to do this or implement this, people who will require just one pill a day may even end up avoiding that. And this is also important. Professor Bruce Neal talked about the risk in chronic kidney disease. So this was a modeling study done on low sodium salt substitutes in India. And this showed that, and this was the modeling approach that was used, looking at cardiovascular disease mortality in the whole population if the salt supply was switched to the salt substitute, and separately in chronic kidney disease patients as well. So this is very important. And what it found is that if you look at this graph, and I don't need to really emphasize every single point, but you see that all the points lie to the left of the vertical line that you see here, which means that the mortality is reduced by using low sodium salt substitute, no matter which subgroups you look at. And most importantly, even if you limit this analysis to population with chronic kidney disease, the directionality is the same, and potentially the benefits are statistically significant in the largest proportion of people with chronic kidney disease. So this is something we need to study further, and we have currently put in a grant application to the Indian Council of Medical Research to study the safety of using low sodium salt substitute in people with early stages of chronic kidney disease, to ascertain whether it is effective in reducing blood pressure and also whether it is safe, right? Now, if we only look at availability, access, and awareness, the retail low sodium salt substitute has been available in Indian markets for almost 15 years, but the market share is limited and only one company predominates. There are three different proportions of potassium chloride substitution in this low sodium salt substitute. But as discussed, the price is high and the demand really is very low. And currently it is marketed as niche products. The availability, I have to say that it's very limited beyond major cities. Awareness is also low of at least the salt limit. Many people know of low sodium salt substitute, but they don't know that it contains actually potassium, and that potassium is beneficial for health. In one survey, 20% prescribed low sodium salt substitute, but I would say even that is optimistic. There are a number of production barriers which were discussed a little bit ago. India lacks available sources of food grade potassium chloride, and if we start doing it, it will increase the production cost. We also need to be aware of some other challenges, which include cultural preferences, which include the rising popularity of alternative salt preparations like pink salt. We already spoke about it. There are clinical apprehensions specifically regarding people with chronic kidney disease, even though that is a very, very, very small proportion of individuals. I mean, I can say that with some degree of confidence because I'm a kidney doctor, but still that prevents the use of this beneficial intervention in almost everybody. And so there are these populations that require a little more research, which we discussed already earlier: pregnant women, children, people with kidney disease, and those with uncontrolled diabetes, and in the elderly population. So what next? So we are currently embarking on studying the safety of low sodium salt substitute in people with early chronic kidney disease. There is a need to also evaluate the cost effectiveness using global examples, and then most importantly, conduct implementation research for large scale distribution. Dr. Neil talked to you about the adherence, and that's an amazing degree of adherence, and we need to see in our societies as well whether we can achieve similar degrees of adherence and implementation. We need to also undertake dissemination advocacy exercises, and this is one of those, and I'm sure that there will be many more. Our teams are involved in this, George Institute, Resolve to Save Lives, National Institute of Nutrition, and there are a number of other organizations as well, with the long-term goal to enable nationwide switch from the regular salt to low sodium salt for all the beneficial outputs it will have on health. There are a bunch of potential policy pathways also that we need to try and influence. which include developing FSSAI standards and labeling guidance for these products, integrating sodium reduction into various national programs and NCD strategies. We need to support indigenous food grade potassium chloride production, promote public awareness, and explore procurement opportunities in places where we can easily influence large number of people, such as hospitals, railways, and public food systems. There are a bunch of success stories in India which are relevant to low sodium salt substitution, and we should take lessons from them and implement them in our approaches. Last but not the least, and I hope that I'm pretty sure, not hope, but pretty sure that Professor Shailesh Mohan will address those, are the challenges that the consumers pose to us. Some of those have been answered appropriately and beyond any doubt, but we still need to we need to continue to address them. I'm going to just finish with this final slide of key takeaways, and I am not going to read them out because I'm sure you're aware of it already, and many of these things we discussed already. So the most important one single elevator pitch, if we have to make it as a community, we should say that reducing sodium intake through informed and equitable strategies could become one of India's most impactful cardiovascular disease prevention interventions. Thank you very much. I'm very happy to take questions.
Thank you, sir. There are several questions actually in YouTube as well as in the chat box, but I'll quickly sum up 2 or 3 questions for you to answer. Of course, one question that one of our colleagues, Dr. Arlap, asks is, does the quantity of salt intake increase when a person switches to, low sodium salt substitute because they already know that it is going to be low sodium and they think they can eat more?
Right, very interesting. But the fact that this low sodium salt substitute does not taste any different from regular salt would mean that indirectly that there should not be any change in the quantity of salt that people take. And soon, even if they take it because then they feel that given that it's a substitute, they should take more, even very quickly they will realize that it tastes saltier than they like, and they will reduce the amount of potassium that the amount of this low sodium salt substitute that they are adding. So I don't know, I have not measured it, and so I can't answer the question definitively. And I'm wondering whether Bruce knows the answer, but my instinct will be that no, it won't increase the amount of salt that people will consume.
Yeah, I think Dr. Jha, you've answered this question, but however, there is one in YouTube which says, is low sodium salt safe with respect to kidney functions, especially creatinine and EGFR?
Yeah, this is I mean, it bears repetition because this is the most frequently expressed doubt on why people should not be advocating population-wide use. So I'd like to say 2 things. One is that the proportion of people with chronic kidney disease is, even if we take the entire spectrum of chronic kidney disease, it is 8 to 10%, which means we are depriving 90% of the population already. Even in this 10%, it is only people with advanced kidney disease, which is less than 1%, who have impaired potassium excretion abilities, and people who are on certain medications like potassium sparing diuretics or potassium supplement, etc. Right? These people are already under medical care. So this is not part of the general population. And then that becomes the responsibility of the physicians to advise them not to take this. So they certainly should not take this. As I said earlier, that despite the fact that we repeatedly emphasize these points, this concern still persists. So we have proposed a trial to study the safety as well as efficacy of low sodium salt substitute in people with early stages of chronic kidney disease, which includes from stage 1 to stage 3. people with stage 4 to 5, we would also not recommend use of this particular agent.
Yeah, one more important question is on, what will happen to double fortified salt, iodine fortified salt? Fortification, can it be done alongside low sodium and potassium enrichment?
I think that's an easy to answer question. The answer is yes. So the low sodium salt is also fortified with iodine just in the same way as a regular salt.
Yeah, and finally, the questions about how long would it take in India to actually switch from regular table salt to this, and then there are several socio-cultural aspects that come into play, and then would it be easy for the government to take it up, kind of thing?
Yeah, I don't underplay any of these challenges,
Yeah,
and that is what requires a concerted push from all of us who
yeah.
want to do this as a public health intervention. Implementing public health interventions is not easy, especially changing people's behaviors. Uh, and so we have to really take a multi-pronged approach. First of all, the best way of doing it is simply changing the default behavior of individuals, right? And how we can change default behaviors is to ensure, as I said in one of my points, is just to ensure that it gets into places where people will automatically consume that food. For example, in railways, right? Or in hospital supplies, or in midday school meals, and so on and so forth, where we can change it. So that immediately enters there. And then, of course, there are a number of other barriers. We have to look at the cost of this particular agent. We have to look at, and consumer behaviors take longer to change. We have to identify influencers. There is a lot of tradition of using people like Amitabh Bachchan or such people,
Celebrity endorsement, yeah.
celebrities, yeah. So we get endorsements, and we get them to say this again and again and again. We use public messaging on radios, on television, even on movie theaters, just like you have for smoking, etc.
Thank you. That's very insightful. There are several questions, but I'll take them at the end if there are any more that are left unanswered. Now we'll move to our next speaker, Professor Sailesh Mohan. Thank you, sir, for joining. Professor Sailesh Mohan is from CCDC, and then he would speak on consumer perspective on low sodium salt substitutes. I think some of these questions will be answered now. But before he starts, my colleague Tavleen will introduce him.
Hello. It is my pleasure to introduce Dr. Shailesh Mohan, Deputy Director and Head of Cardiovascular Epidemiology and Secretary Governing Board at the Center for Chronic Disease Control. Dr. Mohan works extensively in the area of chronic non-communicable disease research, teaching, and training with a strong focus on the prevention and control of hypertension, diabetes, multimorbidity, and cardiometabolic diseases. He has developed and evaluated sustainable community and health system based interventions for NCD prevention and management and contributes to strengthening high quality health systems and implementation research in low and middle income countries. He also leads and supports major cohort studies, including Precision CARS and UDAY, advancing the understanding of cardiometabolic and neurodegenerative diseases. We are delighted to have him with us today. Welcome, sir.
Thank you very much for the kind introduction. I'd like to, at the outset, thank the organizers for this kind invitation. So I'll try to share my slides. Are the slides visible?
Yes, could you put them in slideshow mode? Yeah.
Yeah, I put them.
But for some reason, yeah. Okay. Right.
All right. So I would like to share some perspectives from a study that we did to promote the use of low sodium iodized salt. This study was supported by one of the organizers in this meeting, the Resolve to Save Lives. So essentially, the objective was to as I said, increase the proportion of households that report the use of low sodium iodized salt. And we did this study in 2 sites in India, in North and in South. And the design was a quasi-experimental study with difference analysis. And we had 2 arms. So in one arm, we provided education on LSIS. And in the other arm, in addition to education, we also provided a subsidy for people to buy low sodium iodized salt. So this slide shows the different stages in the study. So we started off with formative research, which provided critical insights in the intervention development process. And then we implemented and evaluated the intervention. So the objective was of the formative research was to explore the awareness levels in the population, the availability, affordability of low sodium iodized salt, so that we could inform our intervention development suitably. We used in-depth interviews and focus group discussions with various stakeholders, including consumers, retailers, distributors, and influencers, who included healthcare providers as well as community leaders. So we explored different topics in relation to the use of low sodium iodized salt, about blood pressure, the impact of salt reduction on blood pressure, dietary changes, etc. So all of that are listed here. In addition, we had some specific questions for retailers and also for influencers. So essentially, to summarize the key findings, we found that there was generally very low awareness about low sodium salt substitutes or low sodium iodized salt in this case. People were just not aware that such a thing existed. Importantly, the availability was very low. Very few shopkeepers were stocking them, mostly in large departmental stores. And thirdly, we also found that people found the cost to be quite high compared to the usual salt they use. And we found that a subsidy to buy this could be a potentially useful strategy to improve the uptake of low sodium iodized salt. So with this in mind, we developed certain key messages to be delivered by particular messengers. So the messages were focused around the importance of dietary salt reduction as part of an overall healthy diet intake. We also wanted to drive home the message that low sodium salt could replace regular salt, and it could be used in a similar way as regular salt is used. And one of the key concerns, as Dr. Jha also alluded, is the concerns around looks and taste. And in this case, both of them look similar and also at reasonable levels of potassium enhancement, taste pretty similar. So we wanted to push these key messages in the population, along with a nudge to consider purchasing low sodium iodized salt. We used health workers, including frontline health workers, retailers, self-help groups, and other key stakeholders in the community to drive home these messages. And we had various posters, pamphlets, and videos to actually implement this intervention. So these are some of the snapshots of the intervention materials that we used, and these were largely co-designed with the different stakeholders based on insights from the formative research process. We also had a video. I won't play it because of time constraints. It's a 2.5 minute video. And what we did was, in the education arm, we provided interpersonal communication that was delivered by health workers. They also distributed posters, pamphlets, and short videos that were co-designed with the stakeholders, as I mentioned. And we had extensive community engagement. In the other arm, which also had, in addition to education, the subsidy being provided, we had all of the other three elements, plus a provision of a subsidy to the tune of 20.5 rupees per packet of LSIS purchase. So this was conducted a few years back, and it accounted for almost half of the price that was prevalent at that time for a kilo of low sodium iodized salt. And this was paid directly to the distributors. So these are some pictures from the implementation phase of the study in both North and South Indian sites. So after the period of 8 months of intervention, we evaluated the intervention through a quasi-experimental design, as I mentioned before. We had assessments done at baseline and at end-line. So we examined the socioeconomic status. We looked at medical history of all major chronic conditions. We looked at salt use. We specifically looked at the use of low sodium iodized salt. We measured blood pressure, and we also measured urinary sodium and potassium levels. So what did we find? So we approached 1,600 plus households, and we surveyed about 3,000 plus participants. The mean age was about 47 years. Slightly more than half of the participants were women, and a quarter of them had at least secondary level education, and more than 80% were employed. 15% reported hypertension, and this is self-reports, and 9% reported diabetes. When we looked at their self-reports of how much salt they use, at baseline, we found that roughly similar number of people reported using less than 5 grams of salt per day. And this was also similar. The proportion increased slightly, but it was roughly similar at end line when we look at it by the different intervention arms. When we looked at perceived benefits at baseline and end line, there was a slight increase in overall awareness about benefits of consuming low sodium iodized salt, from about 40% to about 60% between baseline and end line. And this is an important slide because at baseline, as I said, the knowledge about low sodium iodized salt was very limited. Availability was also poor, and thus people are actually literally not buying it because it was just not available at their doorstep. So following the intervention, we saw that around 15 to 16% of people were willing to pay more for this low sodium iodized salt, given that they have now understood some of the benefits that accrue from usage of low sodium iodized salt. So this is in a scenario where the subsidy was no longer being provided. When we look at ever use, as I mentioned, at baseline, it was literally zero, but we could increase the ever use to about 50% in the education plus subsidy arm at end line compared to the baseline. And this, we could see that there was a 2.2 times increase in Andhra Pradesh compared to Haryana, 1.3 times increase in the rural side compared to the urban, and 3.6 times increase amongst those who reported graduate level education compared to lower levels of education, 1.7 times more usage amongst those reporting hypertension, and 1.4 times more usage among those reporting diabetes. When we look at current use, again, it was literally zero at baseline, and we could increase it in the education and subsidy arm by the N-line assessment to about 41%. And this was also similarly more in Andhra Pradesh. In urban side, it was slightly more compared to the previous scenario where it was more in the rural area. And those with graduate education used it more. And similarly, those with hypertension and diabetes also reported using LSIS more. We also had a range of secondary outcomes. And first was blood pressure, because that's the most important variable of interest. And we found that there was no change in the mean systolic or diastolic blood pressure. When we looked at urinary excretion of sodium and potassium, again, we didn't notice any discernible difference. But there was a 34% increase in the number of retailers who were selling low sodium iodized salt, perhaps pointing to the fact that we, through the intervention program, managed to create some kind of demand, increased demand in the communities that people started demanding. And as I mentioned before, people are also willing to pay even without a subsidy. So what were the key challenges? There were several challenges. One was that, we worked with the retailers and distributors at the state level. We also got in touch with the manufacturers, key manufacturers of low sodium iodized salt. And it was an uphill battle to ensure that there was seamless supply at the study sites. So that supply process was not consistent. So in the beginning, it was really tough to ensure that the product was available in the shops where the participants were residing. Then midway through the study, we could manage to a better degree, but that proved to be a challenge we could not really surmount. As a result, the availability was irregular or patchy. The second major challenge was, of course, the cost. Even with the subsidy, some of the people were not willing to pay slightly more compared to usual salt. And the uninterrupted usage that we wanted was not possible because of issues related to supply. And that also could have perhaps influenced the outcomes of interest that we were assessing. So when we look at the reasons, potential reasons for observing no change in the blood pressure or urinary sodium and potassium levels, I want to place in context two studies that were conducted previously. One has already been referred to by Professor Bruce Neal. So in both these landmark studies where there was a change in blood pressure and urinary sodium and potassium, one of the key characteristics that could have potentially helped the investigator achieve the outcomes they wanted was that salt was provided free of cost, whereas in this study, we mirrored what's happening in the real world situation, and in one arm, we had people who were paying the full cost, and in the other arm, we are giving a subsidy. So probably this could be one of the reasons. And of course, the duration of the intervention was also short. That could have also potentially led to a non-observance of any significant difference between the study arms. So in summary, what this study proved is that, yes, it is possible to improve the utilization and uptake of low sodium iodized salt in communities that are not aware or using this type of salt through education and subsidy. But we need to be consistent in ensuring seamless supply so that we can observe population level changes in the parameters of interest that we are interested in. So the key issue here is ensuring availability and affordability, which if improved, can really help drive improved uptake and utilization of low sodium iodized salt in the population. I think that's my last slide. Thank you very much.
Thank you, Professor Sailesh, for bringing those important points. But I also see that there was substantial, increase in the people in education arm who were buying low sodium salt. That's 22% from 1.6 odd it has raised. So that's a very interesting observation. Even without subsidy, they managed to get to this. And one question is, how was it ensured that the subsidy that is provided is utilized for this? Was it a cash kind of a subsidy that you provided, or you reduced the price of the low sodium salt in the market? How was it executed?
So we operated through the distributors. So they were given the subsidy. So at point of sale, the consumers had to pay 20 rupees less. So we didn't provide direct cash, any kind of transfer to the consumer, but the consumer had the benefit of getting it at reduced price.
But were the consumers aware that it is much lesser than what it is, or was it
Yes.
20 rupees lesser than a printed on what is printed on the pack? Is it like that?
That was part of the
Okay.
interpersonal communication
Okay.
that was delivered.
Okay. Thank you very much. There is one question. I'm not sure how this is directly related, but the question is interesting. It says, any study to explore the role of potassium in obesity? Not sure. Okay. Okay, we will move to how can communities in rural and tribal areas be sensitized and encouraged to reduce salt intake when many people with hypertension but never had their blood pressure even measured, or they don't even know that they're hypertensive? Probably you would have come across such cases in your rural areas as well.
Yeah, obviously there are people who are unaware that they have hypertension. First of all, as I presented, in our formative research, we found that at least a third of the population is aware that excess salt intake is somewhat associated in some way with the risk of high blood pressure. But they did not know that if you use potassium enriched salt or low sodium iodized salt, you could actually see some reductions in that. So that health benefit between the use of low sodium iodized salt and blood pressure was missing. So that formed one of the fulcrum around which we tailored our educational intervention. So I think if you go into the community, you will definitely find people who are unaware. So at least for our baseline and endline survey, we had few of them, but our focus was not on diagnosing people unaware of their condition, but in driving home the messages to improve the uptake and utilization.
Thank you for that. But we have one question from a panelist. It's a quick question, I hope, and then we'll move to the panel discussion. Dr. Surya, over to you.
Sorry, sir. I just wanted to add to what sir was clarifying. In order to reach these vulnerable communities, what we need to do is explore and exploit the existing health systems. One to utilize a Arogya Ayushman Mandir system, and where they can be first screened, or uh, some government agencies can take up this role of distributing this salt as a PDS. That is how we can reach out to this vulnerable population. That's it. Thank you.
Right. Thank you very much for that point. I think we thought we would reserve that for your panel discussion. Nevertheless, it's very important point that you made. Now is the time for panel discussion. We have, four panelists. All of them are eminent in their own way, doing great work in various fields. We have Dr. Suparna Ghosh from George Institute. She's a program head in nutrition and food policy. Then Dr. Meenakshi Bajaj, who's a very well-known dietitian from Tamil Nadu government. And we also have Dr. Surya Gaud, who's our own scientist who's working in this area of promoting, potassium enriched salt. And then Murli Sharan from our sister institute, National Institute of Epidemiology, who is also working in this area of behavioral change communication related to low sodium salt substitutes. I will request Ms. Shushmita, my colleague, to introduce the first two panelists, and then our adolescent nutrition ambassador of Let's Fix Our Food. Miss Amulya Kara would introduce the other two panelists. Quickly, all introductions first, and then we'll move to the panel discussion.
Yes, sir. We are privileged to have an esteemed panel of experts leading our discussion today. It's my pleasure to introduce our first panelist, Dr. Suparna Ghosh Jairat. She is a program head of nutrition at the George Institute for Global Health, India. She is an expert researcher in public health nutrition with a focus on food systems, nutrition policy, dietary diversity, and non-communicable diseases. Her work includes leading a pioneering research on indigenous and sustainable food systems aimed at improving nutrition among vulnerable and tribal communities. She works on maternal and pediatric nutrition, strategic behavior change communication, and diet-based interventions to prevent NCDs. She serves as an adjunct professor at Manipal Academy of Higher Education and is a valued member of National Nutrition Advisory Committees. We welcome you, ma'am. And next, I am delighted to introduce our second panelist, Dr. Meenakshi Bajaj. Ma'am is a registered dietitian at Tamil Nadu Government Multi-Super Specialty Hospital, Chennai. She is an expert in clinical nutrition with more than 3 decades of experience. She is an expert in providing nutritional care for people with diabetes, renal disease, oncology, respiratory conditions, liver and metabolic disorders. She additionally serves as a faculty of clinical nutrition at Madras Medical College, Chennai. Her research focuses on gestational hyperglycemia, diet metrics, low FODMAP nutrition, and evidence-based clinical dietetics. She is a recipient of multiple professional awards and recognitions for her outstanding contributions to clinical nutrition and healthcare services. We welcome you, ma'am. Now I would request Amulya to introduce the other two panel experts. Thank you.
I am pleased to introduce Dr. C. Surya Gaud, a public health nutrition researcher working at the intersection of dietary risk factors and non-communicable disease prevention. His work focuses on reducing sodium intake and addressing hypertension with an emphasis on developing scalable nutrition interventions. He's currently focused on researching low sodium salt substitutes in India, and also actively contributes to translating scientific evidence into nutrition policy and public health practice. He is also the recipient of the Young Scientist Award from the Nutrition Society of India. We welcome you, sir. And for the next panelist, I am delighted to welcome Dr. Sharan Murali, a public health specialist working in applied non-communicable disease epidemiology and implementation research. His research focuses on hypertension, chronic kidney disease, and dietary salt reduction and behavior change interventions. He leads an ICMR-funded multi-state project on health worker-led salt reduction counseling at health and wellness centers. He's also a faculty member for the India Field of Epidemiology Training Program and contributes to the development of digital health systems for public health decision-making. Thank you, sir.
Thank you, Amulya. She's from Johnson's Grammar School of Hyderabad. Thank you very much for those introductions. Now to very important part of the entire e-dialogue series, because there are a lot of questions, people drawn from different backgrounds. My first question to Dr. Suparna Ghosh. We've heard so much about this, and public health and policy perspective is something that LFOF wants to take forward this entire e-dialogue and outcomes of these e-dialogues too. So what are the strategies that you think could help make low sodium salt substitutes more affordable? I think some of them have already been discussed by Professor Neil and Professor Jha. More affordable and accessible. That's very important for diverse Indian populations, taking into consideration not just their economic spectrum, but also the cultural diversity that we have got. Over to you, Dr. Suparna.
Thank you, Dr. Subbarao. I think Professor Jha and Professor Bruce Neal have spoken about some of these key areas where we need to have interventions so that we make low sodium salt substitutes more affordable and accessible. From the affordability perspective, the raw material, the potassium chloride, that needs to be available. The food grade potassium chloride, that is a big hurdle. If we don't have large scale supply of food grade potassium chloride at reasonable cost, the affordability will be a big issue. Having said that, if we can impress upon the policymakers and make LSS as an important component of the salt reduction strategy in India, and show, and the results and studies have clearly shown how effective it can be, and it is such a low hanging fruit wherein a simple intervention, no pharmacological intervention, nothing, just changing something which is sitting on the shelf, just changing the salt jar and just changing the constituent of the salt jar with this LSS. If we can really make a great case for LSS, then perhaps subsidies, incentivization for the manufacturers, and subsidies to the people like GST. It's normal salt is GST free, but LSS isn't, and that's why it is double the price. But affordability, if we talk about, say, instead of 20 rupees, they're spending 40 rupees. But look at the small fraction of the diet that is being, that needs to be, we need to pay a little bit extra for a small fraction of the diet. So it is not much. And I think the next point to make it more affordable is to make it accessible. And here, a little bit, we just can't say that it is just purely changing the supply, but also a little bit of behavioral nudge that, you have to go to the shop and pick up the right salt packet. That salt packet should be available in the food environment. So we hardly see them displayed at the front line of the shelf. It is somewhere at the back. People don't even know about it. So behavioral nudge is important to make salt accessible. Apart from that, clear labeling, because we are still talking about that little bit of apprehension. So if it's some advisory is there on that packet, which says that, yes, it contains potassium. And apart from that, I think clear front of pack labeling, a behavioral nudge, and of course, incorporating this salt into the public food procurement programs like the PDS. And Dr. Meenakshi was telling us the other day that it was incorporated in Tamil Nadu as part of the public food procurement program, but there was no demand for it. So another thing is, if we increase the demand, economies of scales will come and people will ask for it. So there is a demand, there will be more supply, and the industry will be motivated to, produce these salts. They can make pink salt popular. They can make
Yeah.
several other salts popular. So public-private partnership here is also important, that we ask industry to participate in this awareness campaign. I'll stop here.
Thank you. Thank you very much. We see on the pavements just outside our workplace and NIN, on the pavements, huge trucks selling the rock pink salt. And then people don't mind shelling out a lot of money to buy it, thinking that it is healthy for them. It's all about a behavior nudge that tells them that, those do have similar amount of sodium than, when compared to the regular salt that we consume, and low sodium salt substitutes are better in terms of, what they choose for their consumption. That's a very good point. Thank you very much. And I'll go to Dr. Meenakshi to ask her, from her regular practice as a dietitian, how commonly do you encounter people in your patients or families regarding potassium enriched salt, thinking that it is not good for them, and then how do you address them at your scale?
Thank you for the opportunity, sir. So basically, when we have patients coming to us, very rarely a patient will come to me and ask me, so I'm choosing on a potassium salt, should I continue with it or not? So it's the other way around. It's the dietitian who does the prescription and tells the patient that we want you to move over. First we want you to reduce the salt, and then we want to substitute your regular salt, a regular iodized salt, with low sodium salt substitute. And I would say the first barrier there would be, okay, sensory. Is it tasty? Is it going to give me the same taste? Can I use it for my entire family? I'm only 30 years old. They've just found out that I've been hypertensive. age, I'm very young. Do you think I need to switch over now? So these are certain apprehensions which they have in their mind. And the first thing, as I would say, sensory evaluation. Definitely, believe me, I have been on a low sodium salt substitute. The reason being that we have a very strong family history of CVD, CABG, you call it, you name it, CKD, stroke, all of it. It's not that just because I'm using it, the whole world should use it. We have evidence like how we had Dr. Bruce as well as the former speakers talking to us about the SSASS trial. We have to convince the patient that it is useful. How is it useful? Not only hypertension. Believe me, we see a lot of patients with CS stomach. We see osteoporosis, postmenopausal women with osteoporosis. So we don't limit ourselves only to controlling blood pressure. We don't limit ourselves only to prevent stroke, CKD, or major cardiovascular events. We move a little further and say CS stomach. We move a little further and say osteoporosis. So once I've convinced my patient that it's not going to benefit only one, it's going to benefit so many factors, the patient is definitely convinced. Secondly, I tell them the 75-25 ratio, even the 15-30%, whether you choose a 15% or a 30%, there is absolutely no difference in taste. But I would want to make a mention here. I think one of the questions came from one of the viewers that do we add a little extra salt? Believe me, we do add a little extra salt. But when we add that extra salt, we are adding extra potassium also. So we bear that in mind. And when we are, promoting this product, we also tell the, producer to provide a 5 grams insert of a spoon so that the patient knows that this is the salt I'm supposed to consume. Now, how do I prevent that additional extra salt which I'm adding to meet my sodium taste? My palate is used to it, right? So my palate takes about 21 days to adjust and reduce the sodium intake. So usually we follow the approach of dietary approach to stop hypertension. Tell them 1 meal a day will be salt free. What is that salt free? How can I eat salt free? Oh, believe me, that first thing when I tell them go salt free, they are like terrible. So we tell them take fresh fruits, add some squeeze some lime over it. So I'm going to enhance the flavor by some spices and herbs. So add some mint, add some lemon, some oregano, some parsley. All these things will enhance the flavor. So I don't need that extra salt. Even if I want to add the LSS, I can add, no issues. Only thing I'm enhancing the flavor. Now the next thing is cost. Everybody is talking cost, cost, cost. Believe me, I don't take it like cost. I say penny wise and pound. Why I would say that is 1 kg of salt is going to go 200 days. Okay. And second thing is, for example, I'm taking 28 rupees for the regular iodized salt. I'm going to pay 40 rupees for the 15% reduction, and then I'm going to pay a little more higher for the 30% reduction, whereas trials tell us 75-25 is more than enough. So this small margin of 12 rupees is going to be divided over 200 days.
Okay.
So believe me, cost is not the issue, because one packet of biscuit one buys, easily you spend 5 rupees, and you'll be spending only that 5 or 6 rupees extra through the entire 200 days. Entire 200 days. So cost is not an issue. But yes, as you said, as Suparna ma'am and others said, that there is a main ingredient which has to be, purchased in large quantities. So availability, definitely that could be thought of. And there are some misconceptions that is it safe? Yes, I think WHO has given us clarity, and even the former speakers have given us clarity. Yes, if you are having polypharmacy, a list of pills, it has to go on the prescription. Otherwise, if it is advised once, I think you can pick it up from the market. But if you are having a polypharmacy, definitely you need a prescription.
Thank you. I'll share my own experience. In my home, I quietly replaced low sodium salt, and nobody even realizes. Nobody even read the pack, and the pack keeps coming every month, but nobody reads the pack. They just use as much salt as they used to use earlier, and I'm sure we're not spending more on buying extra, salt. That means consumption is not any higher than what it was earlier. This is personal experience. It should, I mean, it need not be everyone's experience though. Yeah, I'll get to Surya now. Surya, you've done some organoleptic studies in Indian scenario, and what is your take on that? How do people see the properties of this salt as compared to the others? What have you done? Please tell us.
Yeah, sir. It was a very rich experience participating in this. Almost every speaker is talking about this concept so much. I have very little apart from this, so let me talk about that, sir. What we have done was basically to test the regular salt with two variations of low sodium salt, that was 15% and 30%, which were available in the market readily. We didn't manufacture them, they were readily available in the market. So we took that and tested it on three commonly consumed Indian recipes. They were namely dal with a roti, dal with roti, French fries, and a liquid medium buttermilk. So it was a semi-solid. Dal was totally mixed in it, and second one was French fries, where we topped the salt, and third one was buttermilk, which was totally a liquid one. And many people consider that young generation and the non-hypertensive people feel, why should they take this? So we did this study on analytical study on college students, basically, who were none of them were hypertensive and none of them were even, they were not even old, they were college going students. So we found nothing significant, sir. Taste, as far as the analytical taste perception was noted, there was no significant difference in either of the three compositions. Though I would cautiously read it because it was done on a small subject group and not a consumer panel. They were semi-trained panel. We basically had a screening criteria to screen whether the students were able to distinguish between basic tenses, basic tastes like sweetness, sourness, bitterness, etc. After they cleared that level only, then we have given them different amount of salt mixed in water, 1 gram salt, 2 grams salt, 3 grams, and we asked them to rate that. After clearing this tests only, two level of verifications only, the participants have actually tasted our dal with roti, French fries, and buttermilk.
Buttermilk. Okay.
Despite this, we were confident to tell that we are about to publish this paper in a journal. We are preparing the manuscript. Very soon it will be out. But there is no significant difference as far as the saltiness perception is noted.
Thank you. That's very useful for all the questions that we are getting on YouTube as well. And Dr. Suparna, and before you, I'll go to Murli once, and then I'll ask him from epidemiological standpoint, what are the groups you think will benefit the most from low sodium salt? And is there any caution that you would advise to any of the groups? Because you're doing a study in multiple states. Yeah.
Yeah. Thanks, Subbarao sir, and all the organizers for this invite. And it's fantastic, like what Surya said, everyone is talking about LSS. That itself is a great win, to be frank. So I believe, so I primarily work in two states, that is Telangana and also in Punjab, with the health system there. And we are trying to do something with the individuals with hypertension who are taking care from the Aishman Arogya Mandir or the arm clinic that we call. So we believe that people who are taking like monotherapy, I think that's the same thing what Dr. Jha was also able to tell. People who are on a single antihypertensive will greatly benefit if they start, using the low sodium salt. And because it will definitely bring down their blood pressure by almost 4 to 5 millimeters. And in that way, we can ask them to switch to LSS and stop having one pill basically. And the next group is basically individuals who are in the pre-hypertensive stage. So in the Instagram era, we understand that the gym culture is increasing. People are very happy to have avocado toast and stuff, but they are not talking about LSS. So this is one group which can actually get benefit out of this, because their BP is a little high. The doctor doesn't want to start them on drugs, and these individuals start going to the gym or maybe a morning walk and start diet. But they will also get advantage if they shift to a low sodium salt substitute. And any other normal individual with an adequate kidney function can safely switch to LSS. I agree to what Subbarao sir said, because I also changed. I feel the change should start at home. So I changed to LSS, me and my wife. And we both are very happy with the way it's treating us. Nowadays, when I travel and when I take a food from outside, I feel the food is very salty because my taste buds have already adapted to it. While speaking all this, we need to have a caution that people with advanced kidney disease and those who are, having drugs which can actually store potassium in them, they will have to have a caution while taking the LSS. So primarily, we understand that our hypertension treatment protocol has got telmisartan as a drug from step 3 onwards, which is primarily an ARB. And if we have to take care of this particular group, which is coming around, 2 to very less, 1 to 2% of people who are at that severe disease who are on ARBs, then we can expect a 2 to 5% risk of hyperkalemia, which can also be sorted provided they are on regular follow-up and they watch out for the symptoms with regular potassium monitoring. So this is definitely a doctor's call, but I would like to recall what Dr. Jha said. We are depriving 90% of the population of the benefits of it if we don't, start it at least now. Yeah, so I hope I was able to bring the light to the people who can take benefit.
Right. Thank you very much for that. Now I'll go to Dr. Meenakshi again. How feasible it is to introduce? See, I mean, everybody has put this point forth, saying that the initial entry points would be either hospitals, Ayushman Arogya Mandir, ICDS, public distribution system, or midday meal, or whatever. I mean, from your experience, is it easy to introduce it in a hospital meal first?
Yeah, surely, why not? We already have NCD diet, we have a high protein diet, renal diet. So minus renal diet, whether it's a cardiac diet or a diet for a person with diabetes or even a regular diet or a high protein diet, we can conveniently replace the regular iodized salt with low sodium salt substitute. Yes, if we find, we can always, have an interaction with the nursing team, with the healthcare professional team, that this is the implementation which we are going to do. And if you find the serum potassium peaking, please let us know. We will have another meal replaced with the regular iodized salt. Like how in our nuclear medicine department, we do not want iodized salt because they are on nuclear medicine therapy. So we do have separate, preparations for separate fields, but a regular patient, a standard diet, a high protein diet, or a cardiac diet, or a PWD, I think it's good to go. And as Dr. Suparna ma'am already made a mention, in 2014, as early as 2014, we had the Amma Loso, which was available even in the cooperative. Yes, the price may had a slight variation between the regular iodized or no. Midday meal is the right place. And I think Tamil Nadu has been forerunner, whether it comes to the midday meal or even the breakfast schemes. And above 2 years of age, you can comfortably walk in. Yes, if there is any child with CKD, she would definitely make a mention to the teacher where we could, intervene and provide our inputs. So I don't think it's a problem at all, whether it's the PDS or whether it's the, hospital need.
Okay, thank you. That's very interesting, and then also a low-hanging fruit for us to work on. Dr. Suparna, I'll come back to you. I think industry engagement is a must, and then you talked about food environments, and industry dictates a lot of our food environment, and then how the foods are marketed. That's one thing. And how do we navigate through that system and then get the industry aligned with our priorities? I know one pathway is directly asking the policy to be made compulsory, and then everybody goes that. But what else can we do is one question. And the second and aligned question with that is we the potassium that is to be used in this needs to be imported for us largely, like in edible oils, like in many other foodstuffs that we have, even pulses. If we become too dependent on imports, would it be economically feasible for a country like ours? These are the two broad questions.
Yeah, of course, self-sufficiency is the key term here. And there have been there was some patency around, using some kind of a byproduct of salt production and, making food grade potassium out of that, from that byproduct. But I think there needs to be a lot of support from, relevant government organizations to support and incentivize researchers to develop these products. And until and unless we have a policy around it that we have to switch our salt supply, that kind of prioritization, if it happens, then it is likely to lead to R&D. I'll give you a similar example of millets. Like we are saying, eat millet, but do we have policies that will really promote millet production? Similarly, but we understand the importance of millet. We announce the year of millet. Similarly, we can do similar kind of stuff wherein we can actually promote this LSS, and then comes the question, how do we produce enough to switch the salt supply of India? And that is where the R&D and other things will happen, and the other things will follow. Industry, of course, is important because they are at every step of the supply chain, from manufacturing to production to retailing to supply to everything. So basically, when we start, and we know that the Indian food plates are changing rapidly, so do we just stick to discretionary salt, or we also start thinking on making the industry also to utilize this kind of salt? And once they find this as a raw material for their product, they will automatically have ways of, enhancing the production of low sodium salt substitutes. So nudging everybody, for that matter, not only from the consumption point of view, but also from the supply side, I think that is very critical. So yes, industry is important. Of course, incentivizing them, procurement incentives, production incentives, fiscal incentives, all can work wonders. And apart from that, again, making industry responsible. So we talk about the corporate social responsibility of the industry. Make them responsible to popularize LSS. I'm sure they will be able to do it. Social marketing, they can do better than us. And we know that for sure, that if they see that there is a potential and that has a huge health benefit, I think partnering with them is very important. And partnership for public purpose, that's what Dr. Reddy says on PPP. So this kind of partnership for public purpose, where we are addressing hypertension while partnering with the industry, is very critical here. Apart from that, I had one more point. Yeah, like voluntary and mandatory reformulation of products can be also done through
Yeah.
industry, and regulatory guidance from the FSSAI on how to engage with the industry. So disclaimer, not disclaimer, advisories on potassium and stuffs like that should also happen simultaneously, so that the industry has a clear-cut pathway, which is shown by the government. Yeah, I'll stop
Yeah,
here.
one more thing, being on the labeling panel, I realized that this is a good way to actually put a claim on your label, and then if it is
Yes,
allowed. So
it
I
is.
think
It is.
that's
It is
that's
good for your
actually,
health.
positioning
Yeah.
it for health benefit.
Yeah.
Nevertheless, thank you. I'll ask one question to both Surya and Murli. You have to take one after the other. Being young researchers in this field, what are I mean, everybody was saying that there is a lot of contextual research that is required, and what are the pathways for contextual research that you think are good, and what are those lines that you guys are pursuing?
Sharan, you can go ahead.
Yeah,
Okay.
Sharan, you can go ahead.
Yeah.
Yeah.
Yeah. So even though we keep speaking about the low sodium salt and its advantages, the traction in the health system is very minimal. That's what I would say. From our experience, the patients are not, like, I'm talking more about the rural patients who are reaching out to a sub-center. They are not aware that salt itself is a problem. For them, salt is part of their culture. It is something that they cannot live without. So we need to start addressing this from the bottom. So we need to have a more bottom up approach where we do more design thinking with the patients, educate them that this is a problem. You tell us what is the solution that you want us to work it out, rather than we pushing things from the top. Like, we feel subsidy will work, but let me tell you, we did this in Telangana and in Punjab. The patients don't even know what salt they are buying, because when they go to a shop, they ask for the salt. The shopkeeper is the hero. He gives whatever salt he has. So we need to understand that the stakeholders are different for each areas within India, like unity in diversity. And then we start addressing the problems of taste, whether the pricing is the problem, whether we can bring in the advantages for the health benefit, etc. And I'm very sure once the demand increases, the cost is going to come down. It might take some time. And we also need to start, bringing more focus to it, maybe through LSS usage in workplaces, like all ICMR canteens may shift to LSS. Maybe talk to the cookery channels which are on YouTube and tell them to advertise this as a part of their. They might ask for a revenue from our side as well, but we don't know. So all these are contextual research that we need to add on. We need more evidence on this. What can be pushed to get this out? Because we are lobbying against a big community who believes that salt is part. And I think in Telangana there is a saying also that if you eat less salt, you lose your energy. We are people who work in the field and things like that. So it has to be taken from the bottom up approach. Yeah. Surya, anything to add on?
Yeah. Like what Sharon said, sir, I would also stick to the 4 A's approach you taught me well for this setting. That would be first strongly designing our implementation research rather than focusing on the existing efficacy trials. We need to shift towards an implementation research, targeting first A, awareness, next availability, next come acceptability, and finally the affordability. I say affordability is still important, but the last one, because when we convince people that this is healthier, I think affordability won't be an issue. Like many of my speakers have already reiterated. Uh, During one of our recent market survey, which we have conducted in entire 150, all the 150 wards of Hyderabad were covered, sir. In that, what we found was we covered one supermarket for each ward and three local kirana stores for each ward. So to sum up, it was 600 sample size and 150 supermarkets and 450 kirana stores. What we found out was in 150 supermarkets, almost everybody had sold is selling low sodium salt or just sold previously. If not currently available, he sold it in the past. Currently, due to supply chain issue, there was a not availability, but they are away. But when coming to kirana stores, the scenario is very skewed against low sodium salts. I would say only 10% of the kirana stores were actually having that, and they knew the customer personally. Subaru sir will definitely buy low sodium salt. He knew the person by face. For him, he bought one or two packets. That's it, not for general customers. So that is the scenario, sir. Again, one interesting point we found out during this survey was availability of the so-called pink salt,
Pink
rock
salt.
salt in every kirana stores. In supermarkets, so it is available, but it is available in small kirana stores, highlighting indirectly. I won't say directly. I have talked to the customers, but they only store when there is demand. There is demand for that pink salts or rock salt. That is the reason the small kirana shops are also holding them. So the only reason the demand is there because people think that is healthy. Somehow they got convinced that pink salt is healthier. And sir, again, small but important point is the costliest acceptable low sodium salt in the market currently prices around 85 rupees, sir, MRP. But the pink salt, the low sodium 30% wala, madam, it costs around 80-85 rupees. But the pink salt, in contrast, they cost somewhere around 100 to 110 rupees per kg. people are buying the costlier version because they
Yes.
feel it is healthy. Somehow, this Instagram influencers, everybody, not the health system per se, but influencers have influenced the people dietary choices so much. Now every household displays the packet of that pink salt.
Pink salt. Yeah.
Usually, what anybody does it, the moment they buy the salt, they cut it open, shift the salt into a container, and throw away the pack. But the pink salt has given them such a brand value. People are actually displaying it, and unfortunately, even the manufacturers, they spend out of that 100 rupees, 30 rupees goes for the packing. So the package looks very premium, sir. The consumers, I feel they'll feel very stupid when they found out they are paying 100 rupees kg and 30 rupees out of it is going to the packet. So
Okay.
that is
I
one
think
finding, sir.
I think added to your 4 A's that we usually talk about, the fifth A that we need to add is aspiration. So it's not only important to make it available, accessible, affordable, and acceptable, but also make it aspirational. So that's where the branding and marketing comes into play.
And one small one line add on, sir. Regarding the affordability, we had to, for my own trial, I had ordered 6,000 kgs of low sodium salt. The current market value for that was 85 rupees per kg. But for just 6,000, the manufacturer in Gujarat has given me a discount of 20-25 rupees. Now it is costing me only 54 rupees just because of only 6,000 kgs. Imagine a government supplier intending 2 metric tons of salt, the cost will definitely come down drastically if there is demand. It is what my personal experience says. Thank you,
Thank
sir.
you. I think that answers one of the questions in the chat. Somebody said the GST is only 5% on low sodium salt. But 5% on a larger amount adds up to the value. But as you said, if the demand increases, the price may come down. That's a very interesting question. Somebody was asking Dr. Suparna and Dr. Meenakshi, you can take this question, that is it safe for pregnant women? I think that has already been discussed, but if you want to
No,
just
WHO
add.
very clearly says not for pregnant women and not for children below 2 years of
Yeah.
age. And
Yeah.
obviously, advanced CKD and potassium sparing diuretics, ACE inhibitors, ARBs, if there is hyperkalemia.
Yeah. But I think
But I would want to make a mention, sir. I think ICMR made a very wonderful image for World Hypertension Day. So this was talking on the flavor sheet, sodium sheet, potassium sheet,
yeah,
all the
6
six
shields.
sheets.
Yeah. Yeah.
Yeah, that was a wonderful image. I think like how FSSCI had an eat right movement and they had that aaj se thoda sa kuch kam namak. So I think the next movement should be we have to make some noise and say not only reduce your salt, also replace the salt. I think the guidelines also did make a mention of reduction in salt. Probably you can add on the LSS to the guidelines.
Right. Dr. Suparna, you have anything to add?
No, nothing much, but just one more point. I feel it's important to be a part of this discussion is the WHO shake thing, which has just come up, and aligning our salt reduction strategy to that, and which clearly talks about environment. It talks about, engagement and, harnessing industry, surveillance, and adopting standards and knowledge dissemination and all. So all these are put together very well. So aligning our salt reduction policy to that is very critical. Apart from that, as Dr. Meenakshi has already said, that there are some conditionalities put, though which doesn't clearly say that it is harmful, but they are saying that it is not being tested in these specific age groups. So just a need to reassure that it is safe in that group of population. That's all. Over.
Thank you very
I would
much.
say
And that,
control salt del.
sorry?
Control salt del. Control salt del.
Okay, control salt L. Okay. Okay. Thank you. Thank you all. This was very interesting. I think I'm getting more questions. What is ICMR and public health practitioners doing to make industry put a label on high salt? Yeah, we are trying our best. Thank you. A lot of advocacy is going on, and LFOF is doing one of such initiatives. It is in the process. I think we'll see, most likely, we are hopeful that we'll see warning labels. I'm not too sure, but it's the FSSA. We can only advocate for it, and we are strongly advocating. As usual, with every e-dialogue of ours ends with 5 key take-home messages. I have many, but rationalizing 5 out of them is very, very difficult. But I'll try my best. The first thing that we get from Professor Neil's presentation and also Dr. Bharti's initial remarks is that discretionary salt use is very high in Indian scenario, and that in itself is an entry point for low sodium salt substitutes. I think there is a scope for them. Number two is at 25% of potassium chloride and 75% of sodium chloride, it will work wonders. And then Dr. Jha also said that for it can give as much benefit in reduction of blood pressure as a single pill could give. I think that itself is an interesting way of putting it. Number three is that it's not only for reducing hypertension, but I think we should look at it from a preventive perspective, that it is for everyone. Of course, there are certain less researched consumer groups about for whom the safety has not yet been evaluated, and that's one of the research priorities that we have, and I think we should look at those as an important entry point. And one thing that Sharon and Surya said was about implementation research, and implementation research is what is now very much required, because everyone agrees that the easy entry points are the PDS, the midday meal, the hospitals, Ayushman Arogya Mandirs, and many of these. And some of the research is already being initiated by our institute. I think we are taking up 2 studies, and then some studies are in the pipeline. But I think more evidence in Indian scenario needs to be generated. And last but not the least, industry needs to be brought in and to reformulate products using these, and then that can be possible only through regulation and also through FSSA's proper labeling. And I think that's one area that we need to quickly look at and advocate for, that labeling regulations and standards for low sodium salt need to be taken up so that the industry can be brought into the picture. And these are my 5 key takeaways. Of course, there are several in my notes, but I think these are 5. And then, since we talk about adolescents in Let's Fix Our Food, and they have a great role, I think they are also a great entry point for introducing low sodium salt substitutes. And then I'm sure our adolescent ambassadors will take this forward. Well, I have with me many of our partners, Dr. Manika, Dr. Sanjay Pandey, Dr. Preetu could not join today, but I'm sure Dr. Neena Bhatia is here, and colleagues from IFPRI are here, and World Food Program are here. I'm not too sure who has all joined, but if there is anything that you want to add at this point of time, we are still open for a quick 2-minute remark. Any of you, Dr. Manika, Dr. Sanjay Pandey, Dr. Preetu, any of you?
No remarks from me apart from just, saying that this was a very comprehensive discussion, and we're thankful to all the speakers as well as, panel members on shedding light on some very important issues. What we've covered is that there is evidence that low sodium salt substitutes could be very effective in sort of reducing our burden of hypertension. It's not only for, management of hypertension, but also prevention. At the same time, there are challenges like availability, affordability, and acceptance. And there were also solutions proposed during this webinar. I just hope that we all can work together to not only promote low sodium salt, but also sort of look at the research gaps and come together to suggest a feasible pathway for going forward from here.
I would like to profusely thank Professor Bruce Neil for staying with us. And then, Professor Neil, you have any remarks to make before we close? Thank you for your patience and joining us from, yeah.
Yeah, I just had 2 very brief comments. One comes back to the presentation that was done a few minutes ago by Professor Mohan, and the observation there that there was no effect on blood pressure and no effect on sodium. And I just wanted to reinforce there that the project that Professor Mohan did is fantastic for looking at that implementation science piece, the quasi-experimental design. But it's not a strong design for looking at those effects on blood pressure and the sort of the biomedical indicators. And I would hate for anyone to go away from this thinking that this was in any way evidence that it didn't work. That potassium enriched salt won't work in Indian people, and we have very good evidence that it would. So I think Professor Mohan probably explained that, but I wanted just to reinforce that. The second was someone raised the very interesting question about people being undiagnosed in terms of their hypertension. And of course, one of the beautiful things about a dietary intervention like this, if implemented at a population level, is that you actually get to treat the people who are undiagnosed without knowing it, just because you're changing their food supply. And that is something that is not widely spoken about, but is potentially hugely powerful in terms of disease prevention. And finally, I just wanted to say thanks again for inviting me, and great job on a really great content and a really smooth format. It's been a pleasure to be here. Thank you.
Thank you very much. Thank you all. And before I wrap up, I would like to thank our director and DG, also DG ICMR for supporting Let's Fix Our Food, and all my colleagues at NIN, and also my team, which includes Archana, Ishani, Mansa, Kriti, Tavleen, Shushmita, and of course our adolescent ambassador, Amulya, and all the others, including Rishikesh Panda and Bhaskar, who always help us, and then the IT team at NIN, and also all my colleagues who have joined, and an incredible audience who've been here. About 100 of them on Zoom, and then about 35 of them on YouTube Live. So that's a good number of audience. And then we have these recordings available on our YouTube channel. They can be seen anytime. And I'm sure many media colleagues have also joined after the content that they have had in one of our earlier e-dialogues, which was reported widely. I'm sure this will also be reported widely. Thank you. Thank you all. Thank you one and all. It was a great, e-dialogue. And we'll keep the conversation on. We'll work together for implementation research and also other research areas. And then, of course, let's advocate strong for better measures for better food environment for all our people. Thank you all. Good evening. Have a great day.